Let me give a couple of examples of where that has actually driven real change. And you won't be surprised, I'm going to start with the safety program. It's not going to be my only example, but I'm going to start with it. The safety program began in January 2008. About 10% of people are harmed by the care they receive in hospital, not by the disease that they have. Depending on where you look in the literature, it could be much higher than that, but it's at least 1 in 10. 6% of Scottish patients have a healthcare-associated infection. So you're at 6 out of 100 before you kick a ball. And then we have people falling over, we have pressure ulcers, we have people getting the wrong drugs, we have people being operated on in the wrong body part. We have all kinds of stuff going on inside the healthcare system. And your system is no any different from that healthcare system. And our system is safer than the other healthcare systems in the world. And I couldn't have told you that 5.5 years ago. And we now have 4 safety programs. We have one for pregnant women and children, and then we have one in acute hospitals, one in mental health, and one in primary care. Let me illustrate what we've done just with one neat example. So today, in airlines all over the world, they will use, roughly speaking, the same checklist when they take off, whether in Seoul, Korea, or Chicago. They'll use roughly the same checklist. And that checklist will be in English, and it will go through things like, what will we do if the engine blows up? How will we shed our fuel and come back round and land? What will we do if a bird hits the jet engine? So taking that checklist theory, we've applied it to operating rooms. So every time in Scotland you now have an operation, it's pretty difficult to find an operating theatre now that doesn't do the checklist. It's not about jet engines, clearly. It's about, is this the right patient? Is it the right operation? Is it the correct part of the body? You'd think that would happen, wouldn't you? I have operated for 22 years. I've operated in the middle of the night in hospitals I've never been in my life. I have operated and not known the names of the people in the room. I've not known what their job is. So I don't know if that person standing there is the anaesthetist or the scrub nurse. I don't know her name. I don't know how experienced she is. I don't know if she knows where the fire extinguisher is. I don't know if the x-ray's up the right way around. And I did that for years and years and years. And any surgeon who tells you otherwise is lying. I've operated on the top jaw when it was meant to be the bottom jaw. I've taken out wrong bits of people where it should have been a different bit of somebody. I've pretty much made every mistake you can possibly think of, and most surgeons have. There are a few who think they don't make mistakes, but they're wrong. They're not any more special than you and I. They're just human. And the checklist is a way of forcing, introducing human factors into that change. To make one of the elements of the checklist is, does everybody know each other's name? So I am Jason, I'm the surgeon. My responsibilities today are such and such. Not, I'm Professor Leach, and I'm in charge, and I'm going to tell you all what to do. Every time somebody's had a wrong kidney out, or the wrong amputated leg, or something big has happened, somebody in the room has known it's about to happen. When they do a root cause analysis, there's always been somebody in the room who knew, and they haven't spoken up. It's exactly the same with airline accidents. The co-pilots previously couldn't speak up because of the hierarchies, so you have to remove all those hierarchies. So the checklist is just a simple intervention that does that. And it has reduced surgical mortality in Scotland by 20%. Not alone. Lots of other things have contributed to that. Infection has fallen. Care has got better. But this is a run chart. This is a statistical process control chart. The dotted lines are statistically put on the chart. There'll be people in this room who are probably analysts who are already thinking he doesn't have a clue what he's talking about. So these are the lines in between are set by the statistics, and if you get below the lines, it suggests something real is happening. So we've reduced, in Scotland, surgical mortality by 20%. Let me go back to the will challenge. So this, you're all thinking, why didn't they do that years ago, for goodness sake? That's easy. Let's just introduce that. That must be really straightforward. So when a man called Atul Gawande did this research originally, he went to 8 hospitals around the world and they introduced the checklist. And they reduced surgical mortality in Dhaka, Bangladesh, and Chicago, America, and London, England. And they reduced surgical mortality by 46%. They then asked the surgeons, when we leave, when we're no longer doing our research, will you do the checklist? And 60% of them said yes. 40% thought, nah, that's a bit rubbish. They then asked, if you were having an operation tomorrow, would you like the surgeon in question to use the checklist? Guess what? 98% this time. Surgeons are not any different from you or me or anybody else. We're all taught that we are special, that we don't need the human factor solution, that we can just run faster because we are special. We are more resilient than those other people. It's not true. Quality improvement teaches us that the psychology of change is as important as actually the changes themselves.